Oh, it's broken a lot of different ways. First of all, in the US, it's sick care and not health care. And I think that's true around the world.
Professor Snyder, I've seen that you've said before that the modern healthcare system is broken and a revolution is long overdue. I was hoping you could tell me what you mean by that. Why is it broken, and what changes do you hope this overdue revolution is going to bring?
Oh, it's broken a lot of different ways. First of all, in the US, it's sick care and not health care. And I think that's true around the world as well, meaning we tend to treat people when they're ill as opposed to keeping them healthy. And so we need a whole paradigm shift there. And even when they're healthy, if you think about how we run our healthcare system, people typically get in a car or some other form of transport, go to a doctor's office, and it's usually at a very inconvenient time. There's never a convenient time to go to a doctor's office. And when you arrive at that doctor's office, it looks pretty much the same as it's done the last 40 years, meaning there has been very little improvement, a few new gizmos, but for the most part, it's the same. And then, from there, they'll draw a lot of blood and make a few other measurements. And from all this, they still measure very, very few things. And then the biggest problem is they'll make a decision about your health based on population averages, meaning that they'll treat you as though you're the average of the population. And sometimes that's okay, but often that's not okay. Meaning, if you're, and a good example I like to use is if your temperature when you put a thermometer in your mouth, you've been told since you're little it's 98.6, but it actually turns out there's a spread, and for some people it's 94.6. That's actually what's called the 25th quartile. And if you're at that temperature and they measure you at 98.6, they'll tell you you're healthy. But if you're up 4 degrees over your baseline, I guarantee you're not healthy. So that's a big shtick of ours. Know what your individual measurements are so you can see a shift.
And is that probably the biggest flaw or fundamental issue with the healthcare system at the moment, is that the medical professionals are looking at one number. They're not looking at what that number is in relation to the individual's baseline. It's all about that difference from what it normally is.
That's one, yeah.
To put
Yeah,
it,
we think that's one of the biggest problems out there. Exactly. That people, even if those old numbers are sitting in your medical record, nobody looks at them. They look at what it looks like today when you had you get your measurement and they'll evaluate based on that. But your trend could be heading in a very, very poor direction. And we've had examples of that. So we've been following 100 people for quite some time. And we had one person, he was in the normal range for his liver enzyme, and then it shifted up, like it was doubled actually, but it was still in the so-called normal range. And wouldn't you know it, so he asked me what's going on. Nobody ever flagged it to him. And he asked me, and I said, why don't you go get another measurement? That doesn't look good to me. And sure, so he did a week later, and wouldn't you know it, he went out of the normal range. And if he was following the normal healthcare system, he probably wouldn't have gotten checked up for 2 years later. And by then, who knows? So we like the idea of looking for these shifts so that you can basically tell when things are off.
so the revolution you've spoken of, what needs to happen, and I guess more importantly, how likely is it to happen? The changes you want to see.
Well, I think it'll be stepwise. So there's many, many things. One is I like the idea of getting a lot of measurements at home, the so-called remote measurement. And we do this in two ways. We do it with wearables, and we can get into that. So I'm wearing my 4 smartwatches. These hearing aids I have, they are for hearing, but they also measure other things. I have a glucose monitor, so on and so forth. So we think this remote monitoring is super, super powerful because it's following you 24/7. You can see really what's going on. And we should talk a little bit about the glucose monitoring because that's a big deal. And then more recently, we had a paper out where you can do little pricks of blood and collect them at home and mail them in. And in the lab, we'll measure 2,200 molecules, many of which are pretty key for your health. We formed a company around this called YOLO that actually measures the commercial, and it'll measure 500 metabolites that, again, are fairly important for your health. So we like the idea that for a lot of routine measurements, you could actually, do it at home, get some pretty important information, and then therefore do it more frequently. These tests should become really very, very cheap. So I guess there's many aspects that change. One is how often you get measured and making it convenient so people do get measured often. We think measuring a lot more is a big deal. Just getting 15 things like they measure now, well, they may catch some things and may miss others. And if I could back up a little bit, I think one of the biggest things we've done is that we started profiling people as a pilot study, over 100 people, 109 people, where we'll do deep data dives on them, measure all kinds of things, their blood, their urine, as many molecules. We sequence their DNA so we can make risk prediction, and so on and so forth. And at the end of and we measure them every 3 months. And just from the first 3.5 years, half the people, so 49 major health discoveries came out of that. So some people had 2, so I think it was 47. So 47, nearly half the people learned something pretty important about their health, like we caught early lymphoma, we caught 2 people with serious heart issues, we caught 2 cases of a precancer. And so we think this deep data dive gives you a much, much clearer picture of your health. And then if you do it longitudinally, you can track it. So those are the key features, we think: big data, longitudinal tracking, and then ultimately make it very convenient for people to do it remotely.
You said that the medical profession hasn't changed for decades, for 40 years, and that we're currently waiting too long and being too passive. We're waiting for an illness to present itself before we even take that first step. How do you see that the integration of technology, health, big data, moving towards this personalized healthcare model? What are the big opportunities and the immediate opportunities you think we can grasp within the next, say, 3 to 5 years? But on the flip side, what are the big obstacles remaining to be overcome that are still the blockers to this kind of rollout that could have profound changes on an individual and society?
Yeah, great question. The problem is the biggest obstacle is who pays. At least in the US, no one pays to keep you healthy. The system is not incentivized that way. Physicians typically get paid when people go see them, and people usually go see them when they're ill. So we need a reward system for getting people to stay healthy. So imagine you get a discount on your insurance if you walk your 10,000 steps. Here's another case where wearables are powerful. Other things. I think you should get a discount if you get your DNA sequence, because you can make predictions about your health and track those things better. So we think that you could figure out ways to incentivize the system to keep people healthy, and then we would be practicing true healthcare and not sick care.
And just how far away are we from some of those breakthroughs? I'm trying to get a sense of just how big the obstacles are.
Yeah, well, at some level. So I mean, here's how we're doing this now. So I'm an academic. We do all these things in a lab and show that it works. And then we spin off companies that come from this. So as an example, we have a company called Cube Bio that does a deep data dive on people. And a lot of people have signed up for it, but they have to pay out of pocket. Again, because the system doesn't do it. I'll come back to that in a second. Same thing for this test I mentioned, where you get the little prick of blood and you mail it in, and we give you back a report. Same thing, you pay out of pocket for that. We have another one called January AI that does continuous glucose monitoring. And that stuff is so powerful, following your glucose, because you can see, it turns out, if we back up, I'll digress a little bit. So it turns out, diabetes is a rampant problem. 9% of the US is diabetic, 33% are pre-diabetic. And it turns out that means you have high glucose, and different people, turns out, react to different foods differently. So some people will have elevated glucose after eating a banana. Other people, it's pasta. Other people, it's potatoes. Other people, it's bread. We're all different. And you can measure that with these glucose monitors. Very, very powerful. And so you can see what foods spike you, and that particular company has a big food database, so they can make food recommendations. Oh, you like this and it spikes you, well, eat that instead. So you can do things that, and even if you just wear one of these things, we've shown it's very, very eye-opening. People will basically watch what they eat just by wearing one of these monitors. They're super powerful. So I think we can do some behavioral modifications like that by visualizing what's going on in real time with your health. Same thing, it turns out, for some of the wearables. We can show when people are getting infectious disease from a simple smartwatch. So some of this you can do, we think, in real time by just showing people directly their health data. But other cases, we do need to rearrange the financial structure, and that's not trivial. I think it can get implemented in these single payer systems, like Europe is often single payer, Canada, places like that. The US, it's so fragmented, it's hard. Nobody wants to, people change their providers every 18 months. So nobody really wants to put a lot of money into you, and 18 months later, you're going to be with somebody else. So we need new structures.
In many countries, the US being the prime example, there are no financial incentives to make people healthier or to make healthcare cheaper, right? For a lot of these companies, big pharma, it's in their interest to have sick, fat, tired, depressed people because it's a cash cow for months, years, decades. How are we going to square the circle between the societal need for us to take better care of each other and to get fitter and happier and improve that quality of life with tackling these huge conglomerations who have got the opposite interest at their heart?
Yeah, well, I don't know if per se if pharma's trying to keep people ill, but it's true they're not incentivized to, they want to give their pills to everybody who's potentially who will react positively to them. I think the issue is, but how to get it possible, how to get this financial incentive aligned is a big deal. I think your employers should be one, especially big employment firms. Many of them do offer wellness programs now, which is a good thing. I think it's in their best interest to keep their workers healthy because that makes them more productive. So I think that's a good one. Stanford certainly does it where I am. Yeah, and then I think your insurance company should give you discounts for people who walk their 10,000 steps, or your provider every day, because that should keep you healthier and you can track that sort of stuff. And there's ways to tell people are cheating. If you throw your watch into your washing machine, we'll know that. The GPS won't be flying around. So I think, putting it on a dog, I think we can still tell that one too. Yeah. Bottom line is, I think we need to, so employers are one way and providers another way. I think stimulating people themselves, just a lot more awareness that, what they're eating, like I said, some of these behavioral things with this glucose monitoring, it's just very, very eye-opening. And I think if we can figure out ways, I think there's really two ways that motivate people: money and family. So I mentioned a lot of financial ones, but I think family is another good way, getting their family involved. So people say, hey, did you run your 10,000, you walk your 10,000 steps today, this sort of thing. So I think we need as many, things there as possible. And I do think these app-based systems that will be powerful because, that is the biggest problem is people say, oh, you bring in health coaches and things like that. Well, that doesn't scale very well, to be perfectly honest. I think we really need app-based methods to do this stuff.
Do you feel that there are some countries or regions of the world that are more suited to moving away from this slow, expensive, reactive healthcare model to a personalised, proactive model? I'm thinking particularly being in the UK of the NHS, where there might be a more suitable environment for some of these personalised medicine and healthcare breakthroughs to happen first before maybe trickling to other systems where maybe it's insurance-based or it's paid for medical service. Is that something that you think about in terms of where can we, as someone who's so invested in personalized healthcare, where do you think are the great white hopes of where this tipping point is going to come from?
Yeah, I think NHS in the UK is a good one. I think the Canadian system tends to be pretty single payer as well. So again, and I think in the UK, they also are really getting a lot of awareness around genome sequencing. It's mostly for solving diseases, but I think they're talking about bringing it in, and there are a few pockets here, like there's something called Geisinger that had people get their parts of their DNA sequence for making risk prediction. So I think a biggie is showing utility. If you can show, hate to say it, if you can show you save money in the US, that would help too. And so I could see this rolling out in certain sectors. So for example, people at risk for cardiovascular disease, those would be good ones to do this deep data profiling, longitudinal, get your genome sequenced kind of thing. And the reason they would be a good group is because if somebody gets a heart attack or what have you, they wind up on long-term disability. It's super, super expensive. So if you can, that might be a way to start, you see, to get this rolling here to get it in. And then suddenly you realize that does save money, which I think there's been some economic modeling that big data approaches around cardiovascular disease and people at risk would actually save money. So I think that's not a bad way to start it. I think there's other ways to think about this too. Like I was mentioning before, the wearables are very, very powerful. They're very inexpensive, relatively speaking. I mean, expensive ones here probably are $300-400. And in the future, even a $50 smartwatch can tell a lot. Follows your resting heart rate, tells you when you're getting ill early. So I think that we could spread out to everybody now, quite frankly. Can you imagine starting a program? You're an insurance company or a provider. Let's put a smartwatch on the whole UK population. Very, very doable and not unreasonable, right? We'll give you a $50 to get a smartwatch for everybody in the UK. And if you want to upgrade it to $100 one, put in your own 50. Very doable. I'd be curious to see what kind of health benefits that has by doing. But then but now keeping wearing the watch could be a little tricky, but we'll figure out ways around that.
I want to get into some of the kind of blue sky futuristic hopes that you've got in terms of personalized medicine. But before we get to that, I think a lot of people would be very surprised by some of the research that's come out of your lab, just in terms of efficacy around current drugs, in that most drugs don't work for most people. It's always kind of for the average. Is that going to be the first and maybe the most important step in the path towards a true personalized system, is that we can identify the right drugs for the right people at the right time based on their genome or other factors that we're getting? Because at the moment, the system it feels like a bit of a lottery whether or not an existing drug for a certain illness is going to work for you or not.
Yeah, I mean, it is true right now. This is on the treatment side. It is trial and error. And, oh, that didn't work, increase the dose or switch to another drug. And unfortunately, I think we're still stuck with that for a while. Now, I think that the area where that could shift earliest might be diabetes, believe it or not, because there are many forms of diabetes and people react differently to different drugs. And there, I think we could try and figure out what the subtypes of diabetes are, the subclasses, if you will. So I think that's a very doable thing. And I'm a good example. So I'm a type 2 diabetic. It was actually predicted from my genome, and it first skyrocketed. My glucose went out of control after a nasty viral infection. I mean, to the point I was diabetic. And I did all kinds of modifications to bring it back under control, and it actually came back again. And I took the obvious drug. It's called metformin that you do for this, and I was a non-responder. But in the end, when we figured out what was wrong with me, my cells respond to insulin. I make insulin just fine, but I don't release it from the pancreas. And there's a drug for that. That worked great. So the point is that I'm a classic case, and we could have figured this all out from the get-go. It took years to figure that out, quite frankly. And we should have just figured it out, in a week. We could have, but the system's not set up for that. So I think that's a good one. By knowing the different subtype of diabetes you are, we can get you the right drug right from the get-go. And I think that would be very, very powerful. I think that'll be true in other areas. Now, it's not quite as well stratified for some of these other areas. Like a lot of the drugs that people take, they're for mental health, for depression, things like this. And there we still don't know enough to say what the right drug is for you versus someone else. So that it is still, so many areas we're still stuck in this trial and error, I guess I'm saying. I think we can get the dosing better and the side effects better figured out from, say, your DNA sequencer. Believe it or not, there's a lot of data around that one. But as far as, which drugs are going to make you respond best for mental health, that's still not so easy to figure out. We need more. That's where we need more data.
In terms of preventative healthcare and medicine, I've read that you've talked about a world in which you're tested your genome sequence before birth, and then all of risk factors can be identified, which means then you're always essentially on the front foot in terms of looking for potential risks, identifying them very, very early, and then offering treatment. In this kind of utopian view of amazing preventative healthcare, it seems ideal, but there's obviously a huge amount of ethical considerations around consent, privacy, data. Is it realistic, is my question? Are we ever going to get to a point where your vision of how all this technology can solve so many needless deaths, essentially, are we going to ever get there, or are there going to be is there too much red tape to prevent it?
Oh, I think this one's totally achievable. This one, even better than the treatment side, at least for right now. Now, treatment, I'm quite confident we'll get there. So this is our big theme: keep people healthy. And I think It'll probably roll out in various forms. I mentioned the wearables and the smartwatches. Those are powerful health monitors. They really can tell when you're getting ill. And I actually first figured out, for example, my Lyme disease of all things from a smartwatch and something called a pulse ox that measure blood oxygen. Just from simple measurements, I saw things were off. And then the timing was such, it was 2 weeks after I had been in a Lyme infested area that I sort of guessed what was going on. And actually, the story is an interesting one because the doctor pulled blood from me, said my immune cells were up, wanted to give me penicillin. And I said, no, I need doxycycline, which is what you take for Lyme. And that cleared it up. But it was tense. He didn't like me making a suggestion. But a classic case of why you have to take your health in your own hands. So it cleared it up, and I was indeed Lyme positive. We got tested. And so and we've gone on to show now for respiratory viruses, including COVID, we can actually detect it before symptoms. See, that's the key in all this. So if you're doing this monitoring and all these health discoveries I mentioned earlier, we can actually catch that before people get symptoms. And same is true for infectious disease. Not perfect, it's 80% of the time, but still it's better than nothing. Your resting heart rate jumps up. We can do that today, quite frankly. And I think that will roll into our health system pretty soon. Some people have actually signed up for a study, and some others who randomly come up to me have said, yeah, I noticed my heart rate jumped up, and I'm thankful that we have an alerting system. They said, yeah, no, I checked, and sure enough, yeah, I had these, we have a red alert if your heart rate's jumping up abnormally. And by the way, you can all sign up for it. Yeah, it was pretty cool that, and so someone just came up to me last week with that experience and said, yeah, he was at this party. Most people weren't wearing masks. He was, and 3 days later, he noticed he's getting these red alerts. He was in our study, and he didn't feel anything just yet. He then tested after a few days, was negative, but 2 days after that came down positive. So we gave him red alerts ahead of time, and he said it was pretty amazing. And he also noticed because his resting heart rate was up, and the same is true for me. So we think those you can do with wearables some pretty powerful health monitoring now. So I suspect that'll move into the healthcare system sooner. Other stuff like the glucose, I'd like to see that move, and I think that can move in pretty soon too. This glucose monitoring, because they're over the counter in Europe. I'm pretty sure it's true in the UK. You can get these continuous glucose monitoring, in a store, whereas in the US, you still need a doctor to prescribe them. But they're very, very eye-opening. I guarantee if you wear one of these things, you'll never be the same. The way you eat will differ. You'll see what spikes you, and you'll avoid it. So that stuff can move in quickly. Some of the deep data dive stuff, we're going to have to show it has utility. We have to, people say, oh, that's great. You can measure, 500 things by this drop at home test. And so what? Does it really help people? Does it really work? And so we need to roll out proper studies. I think the believers will do it because, they're motivated to do it. But if we can show utility, then I think it can fit into your national healthcare system. Imagine everyone does it. And I hate to say it, if we show it saves money, then it'll go in really, really fast.
It's not a case that you're worried by any kind of ethical considerations around consent, especially if we start testing, children to get a full profile of them moving forward. I guess that's one consideration. Is cost going to be a problem, or can so much of this be done with a $50 smartwatch? Because with any new technology that could radically transform someone's quality of life and someone's health, I guess there's the imperative need to make sure that it's accessible to all, regardless of socioeconomic class or health history or any other potential reasons that may prevent somebody from gaining access to this technology. Are you convinced, and you seem very, very positive about it, that all of these issues I've mentioned are very, very easy to navigate and move around so that everyone can access this?
Yeah, good question. I think so. You hit several points. Let's start with the cost one. So the answer is, I think the wearable stuff and the glucose monitoring is relatively inexpensive and will get cheaper. So I think the cost problem for those two areas will be, easily solved and doable. And quite frankly, I think if you look at how much money you're putting in the healthcare system now, $50 is background noise. I mean, so I think some of the stuff is super, super easy. But the other stuff like we do the deep data dives with all the molecular measurements, that's expensive. And so as we get it cheaper, as we show utility, parts of it will roll out bit at a time, I see. At some point, I'm a believer, believe it or not, we will be getting whole body scans twice a year, MRIs, whole body MRIs. But why wouldn't you do it now? A, it's expensive. B, it's inconvenient. You have to go to a place where this happens and it takes an hour and 40 minutes to get a scan. Well, one of my companies, Q Bio, can do it in 40 minutes. And pretty soon it'll be 15 minutes, we believe. And so I could imagine a world in which you go do this on your way to the drugstore, and you stop in at the drugstore, get your whole body MRI. Maybe it starts out once a year. I don't know what the number will be. And then you draw some blood and get a whole bunch of measurements. I think that can be done fairly inexpensively in the future. Now that is further away, but the wearable stuff and the CGM, continuous glucose monitoring, that's here now. On the issue about privacy, I'll be an outlier here. I say get over it. It's not going to be that private, but we'll do it anyway because it's good for us. So the analogy I like to use is your credit card. We all have credit cards because nobody wants to walk around bags of cash. That's not very convenient. So it's a useful way to do things. And I'll tell you, we all have credit cards, and there's a lot of personal, a lot of private stuff on a credit card, probably that's more important or more concerning than your health information. And I'm a good example. I have 2 petabytes of data out there in public, including my genome sequence that anyone can access and work with. We do it for scientific reasons, but and I've never been abused by it, and I don't expect to be. Now you might say, well, he's a tenured professor, so he can get away with that. But yeah, we do need laws to prevent discrimination. That I do believe. But and I think any wealthy society, of which I consider most of the Western world to fall into that category, we owe it to our citizens to keep them healthy and have some level of health care to do that. So bottom line is, I think privacy, your bank accounts, anything can get hacked, quite frankly. And I think your health, and for sure, we'll do everything we can to keep it private. But I think it's not as big a deal as people make it to be.